What I'm going to do in this next section is I'm not going to rush it. I'm going to get to as much as I can. Whatever I don't get to, I'll get to next week. Okay? So we still got, I'm going to have to time myself with this. Anyway, so let's start with pharmacokinetics. This is now going to take what we just talked about in the last 2 hours and now going to apply it specifically to inhalational agents. Okay? And this is more of a practical application discussion of how we do our job. Okay? The key points in this discussion is going to go over alveolar partial pressures. It's going to then describe to you the pharmacokinetic properties of inhaled anesthetics, going from how medications are absorbed from the alveoli to the capillary. And we'll talk a little bit about distribution, elimination, and metabolism. Elimination for most of the anesthetic agent that we're having is through distribution from the blood back into the alveoli, back out to the circuit, and out into the environment. Okay? So elimination really is not due to hepatic metabolism and renal excretion most of the time. And then we'll talk about recovery, the concept of time units. If you understand this, you'll really be good at extubating people. I teach this all the time in clinical. I've had seniors when I used to work by almost exclusively at North Collier at one time. I used to have most of the seniors by the time they left there, they were extubating within 30 seconds of them finishing the case, which is what your target should be by the time you finish this program. So that's what you want to look for to be able to do. The first thing concept is alveolar partial pressures. And the way I think about it is the number of particles that can get into the alveoli at one time. Okay? And simply that's the concentration gradient. The greater number of particles I can get into an alveoli, the bigger the concentration is, the more rapid the medication can get into the blood. So clinically, we can't describe it as a number of particles. Instead, we use a concept of basically partial pressures. And we go back to the initial equation, which is PV nRT. Okay? So if we know the number of particles would be like the n value, okay? And pressure is directly proportional to that. Okay? So if you increase the number of n value, you'd expect the P value to go up if the volume stays fixed, which is essentially what you're doing. Okay? So why is it important? Because if you understand partial pressures, you'll understand how fast you can get a molecule in high enough concentrations into the alveoli to get the effect that you desire. The alveolar partial pressures, which is the P big A, has to do with the input, how much medication you're putting into the lung, minus the uptake. Okay? If you're extracting a lot of medication into the blood, then the actual alveolar concentration falls. And what that basically does is it slows my induction. Okay? It actually drops my concentration gradient down, so it becomes a limitation on how much medication I can get in the bloodstream. Versus if I have something that's very insoluble, okay, but it still has enough potency, as I give it in that patient, the concentration in the alveoli stays fixed and high. And that actually helps me get the concentration to where I want it in the blood more rapidly. Okay? So input has to do with the anesthetic gas concentration, which is the inhaled partial pressure. It, of course, if you go up in altitude, what happens to partial pressure? It goes down. Okay, so is it more difficult to put somebody to sleep at higher altitudes? And the answer is yes. It takes longer to induce somebody because the number of particles you can stuff in the alveoli are less. Okay, so people that are working up in Denver may actually have a noticeable difference in putting a little kid to sleep. Okay. You can also have differences in characteristics of the anesthetic breathing circuit. Okay, if you have a lot of problems with dead space in the circuit, then you actually are causing issues with the anesthetic uptake. The alveolar ventilation is always critically important. If you're moving gas into the dead space, it's not going to work. You really need to get gas into the alveoli for it to be effective. And patient's functional residual capacity is also very clearly important. Okay? The uptake at the alveolar level is dependent on solubility of the anesthetic gas, and we measure solubility, and you're going to memorize these numbers, which is the blood gas partition coefficient. That tells you how much percentage particle will be in one compartment to the other. If we're using blood gas, that means we'll have so many units of blood, percentage of compound in the blood compared to in the gas state, which is the alveoli. If I tell you that you have a blood gas partition coefficient of 1, that means you have 50% in the blood, 50% in the alveoli. Okay, if I tell you that you have a partition coefficient of 0.45, that means that agent is insoluble in blood, okay, and that means I have a higher percentage of blood, higher percentage in the gas component in comparison to the blood. If I tell you that the blood gas partition coefficient is 1.46, that means that I'm going to have a lot more of the compound in the blood in comparison to the gas state, which is in the alveoli. Okay, so we have to think about it that way. Just draw the line in the middle and make it 2 compartments and say, where is the value say? If it says 1, that means 50-50. If it's low, that means that if you take the denominator, blood to gas, that means the denominator is actually lower than the numerator. Okay, so the numerator in this case is gas. Okay, so always pay attention to what's first and second, because that when you actually draw the line, and you can make it basically like this. Okay, and that'll give you the partition coefficient. It also will tell you the health of the alveolar membrane, the area or surface area, cardiac output, and the alveolar to venous partial pressure difference can also be a limitation factor sometimes. Now, how you actually take up medication has to do with the anesthetic input device that you have, which means that how much gas you're going to get into the patient. It's based on the actual gas flow rates. The faster the flow rate I have, the more particles I can deliver per second. Okay? So I can get a more rapid onset that way. If I go to a low flow state, then it decreases the number of particles per second reaching the alveoli. Simple concept, okay, but hard to understand at times. Okay? What you see here is an example of a very old machine, okay, which takes an oxygen tank, simplifies it. It takes the pressure of the tanks and drops it to workable pressures, usually around 50 millimeters of mercury in pressure, and drops it down, okay, from whatever this is. Usually it's atmospheric pressure is like, what, 1900, depending on which tank you're talking about, 2200 for oxygen. And it brings it down, the pressure down, okay? And it makes it workable, so now you can use a flow meter to determine how many liters per minute of gas you can deliver. Okay, so if I put 5 liters per oxygen and 5 liters of nitrous, my total flow rate is 10 liters per minute. That's a high flow rate. Okay? Anything that is double the minute ventilation or anything that's greater than the normal minute ventilation is considered a high flow system. Okay? Now, once that gas goes through, then it goes through the vaporizers, and I'll show you a picture of that in a minute. And the vaporizer then uptakes the gas, whatever you dial the number, and that's what actually gets to the patient eventually. Okay? Here's an example of what we use. This is the circuit that we use, which is a circle system. We actually have a system where we're getting fresh gas flow, goes to the inspiratory limb, okay, it comes around, and eventually reaches the patient. Then it comes back, and the person can, in a high flow system, the person will not rebreathe the gas. In a low flow system, the gas that you're receiving will be basically exhaled, but then rebreathed again, which helps maintain that person asleep. So those are the different components of the anesthetic input devices that you have to overcome before you're actually delivering the gas into the alveoli. The impact of the breathing circuits can be significant in the sense of the volume of the external breathing system or the circuit length can be an issue. Usually the issue restarts at the dead space. Okay? So the dead space is normally at the Y connection. So as long as you don't add a bunch of stuff to the Y connector, it won't be an issue most of the time. The solubility of some of the inhaled anesthetics, if you have a highly soluble agent, it actually will penetrate into the rubber or the plastic, and that'll help keep that person asleep. Okay? Where I think it's a bigger problem is in the actual humidifier. If you see somebody not waking up properly, sometimes you'll see saturation of the gas into the humidifier, and you take it apart and you take it off, and usually the person is awake in about 5 or 6 breaths. So there's something definitely going on with that, which has not been studied, which is something maybe one of you may want to do. You have total fresh gas inflow. The the fresh gas flow, the slower the induction is, and also the slower the emergence is. Inhalational agents have to travel from the vaporizer all the way into the endotracheal tube. So you have a low flow rate, it takes a long time for whatever the concentration that you dial at to get even to the endotracheal tube. Basically, the analogy is the difference between a creek and a rapid river. Okay, in a creek, you still have, say you put dye right here, drop the dye. Okay, and you expect the dye to go down 100 feet down this creek. Well, it's the same concentration as if you would drop the dye up on the top of this river. Which one's going to get there first? The one with the rapids. It's simply how fast the flow rate's going. The same thing. You're dropping literally like some kind of dye into your gas, which is in this case your volatile anesthetic, and you expect it to get all the way down to the lung. You have to get high flow rates for that stuff to get where you want to. Now, the inhaled partial pressures cannot exceed the actual atmospheric pressures. So the maximum you can have is 760 millimeters of mercury at sea level. So if I go up to Denver and my atmospheric pressure drops, my number of particles that I'm going to get into the patient is less. So sometimes it can be an issue and it can slow down my induction. The number of particles getting to the alveoli at a certain flow rate is fixed. Okay, the greater the flow rate, the more particles I can get in. If I give you an example here, let's say we take the dial and put it at 2%, and you're looking at 760 millimeters of mercury. That means at 2% of that means the maximum we're going to get a flow of gas is basically 15.2 millimeters of mercury of gas. If we turn the dial to 4%, then you're looking at up to doubling that of 30 millimeters of mercury of gas that you can deliver to that patient. And that's literally what you're delivering when you start talking about percentages. If you increase the number of hits per second by increasing gas flow, you get a more rapid induction. More gas gets to the alveoli, or you can do it by also increasing temperature. Usually the anesthetics are being delivered in very cold temperatures. Okay, so that doesn't really help you. It slows down your induction. And in the OR, you have a very cold environment. The reason this is talked about is because in the old days, we didn't have air conditioning. And in the summertime, the anesthetic delivery would be very different than in the wintertime. People in the winter would take more to get the medication in to get them to sleep, versus in the summertime, it seemed like people went to sleep faster. It simply had to do with the temperature and the environment that the person was being put to sleep with. You can increase the concentration of gas by changing the alveolar volume by what's called the second gas effect. And we do that a lot when we use nitrous oxide. That's the purpose of doing that. And I'll explain to you what the second gas effect is. You can offset some of this effects by giving high partial pressures. The problem with that is that you can overdose somebody very quickly. And so for that reason, you've got to be very careful with doing that. It's called overpressurization. It basically offsets the impact of uptake and it accelerates the induction. It basically reflects a rapid rise in alveolar pressures. With time, the uptake equilibrates, and you need to cut back on the agent so you don't get an increased dose and overdose that individual. So what you do is we teach you overpressurization. We tell you put your hand on the actual vaporizer, and if you ever get above the normal MAC value or double the MAC, then you keep your hand on there until you know that the value is having effect. You'll see the blood pressure beginning to fall, and at that point you need to cut back, okay, because you're going to overdose that patient if you're not careful. So what you're looking at is the alveolar partial pressures will give you an idea of what's taking place in the brain as well. What we use clinically to tell us what the brain level of an anesthetic is not the inspired fraction of the agent, but rather the expired fraction. Okay? So what we actually monitor is both the inspired and the expired concentration of the anesthetic that we're delivering. What is the most likely to tell you what's going on in the brain is not the inspired fraction, which is dependent on on diffusion and absorption, but it's really the elimination component, which is the expired fraction, that you care about. That's really what's telling you what the brain level's at. Okay? So if you have a choice between which one do you monitor, and sometimes you're told, okay, I need to monitor the gas levels, the ones we want you to monitor on your sheet is put the expired values. That's really telling you what you're delivering. Okay? Recovery from anesthesia will be dependent on the expired fraction. As this falls to 0, then the person begins to wake up. And the anesthetic equivalency was called MAC. We're going to talk about that next week and talk about it for almost an hour. So make sure you understand what MAC is. What you're seeing here is it's a gradient effect. You have the alveolar, which is P big A, followed by the blood diffusion into the arterial side of it, and that's just P little a, followed by P brain, okay, which means the effect goes to the brain. What you're seeing here is what I'm basically describing to you. It gets into the brain, then it gets eliminated back to the venous circulation, and eventually expired. So the expired fraction is the most reliable indicator of brain partial pressures of the anesthetic agents. Now, what we create from this difference is what's called the FA-FI curve. You're going to hear this used a lot, okay? Because this curve is basically telling you how fast the uptake or absorption rate is taking place in that person. If you have something that is very insoluble, okay, the FA to FI curve literally almost touch each other very quickly. Versus something that is very insoluble, the FA to FI curves will stay apart from each other and eventually meet after minutes. We're talking about 15, 20 to 30 minutes in some of the more insoluble agents. If you were talking about ether, you could be as long as an hour and a half, 2 hours, before you eventually plateau together to form this top phase. Okay? So this is the number of minutes that you're administering the medication. This example is showing you 3 different colors. It's showing you the alveolar concentration, okay, which is, the inspired concentration, which is the red line, okay, versus the actual alveolar concentration over time, which is dropping. The reason it's dropping is it's being absorbed. But the green line is the actual FA-FI curve. Okay? What we actually do in clinical is that the machine will actually generate an image of 2 lines. The inspired line, which is a higher concentration line, followed by the exhalation line. And that combined together is the actual FA-FI curve. But in our anesthesia equipment, it'll actually show the 2 separate curves. When you talk about it in class, we tend to just make it into one single line to use that as an example of what really is going on, which is the FA-FI curve. Okay, does that make sense so far? Okay. Now, let's take a drug, okay, like nitrous oxide. If you change the percentage of what you're giving, okay, it takes longer for it to eventually reach equilibration. Okay? The maximum effect, which is the maximum concentration that you can generate into the bloodstream, gets there much more rapidly the more concentrated the delivery is. If you're seeing this individual in the top curve, this is somebody who's been delivered 85% nitrous oxide, which means that they're only having 15% oxygen on board, which is not really a smart idea. Okay? This is an experimental model. And what you see is that person very rapidly gets to the maximum concentration effect within about 8 to 10 minutes. If you use 50% nitrous, your maximum effect plateaus, and you never get to the point that you're almost at 100%, which is not what you ever want. Okay, but 50% still gets you up there pretty quick. Okay, and it's fairly reliable. At 10%, it takes you a little bit longer. But the reason that this still takes place so quickly is because this agent is very insoluble. If you had a very soluble agent, that curve could be very gradual to get up there. It could take a long period of time. The second gas effect is actually something helpful to have with nitrous oxide. Because what nitrous oxide does is in the initial period of it, you see this initial part of this curve, it is rapidly being uptaken from the alveoli. So the alveolar concentration is falling very quickly as it's being administered. Okay? And what that does basically is it decreases the volume in that alveoli temporarily until you reach maximum concentration. At that point, the second gas effect is no longer significant. But during the initial portion, if you think about it this way, if you have 80% nitrous oxide being given to you, 20% in this case is the oxygen, or 19% is oxygen, and then you have another gas, which is a volatile at 1%. When it first gets into your bloodstream, into your alveoli, 50% of the nitrous oxide is taken up. And that brings you down in total volume in your alveoli, so that when you do the mathematics of it, your second gas, which is in this case, let's say isoflurane at 1%, now is jumped up to 1.7%, just simply because you've dropped the volume. Okay, you didn't change anything, except you just changed the volume inside the alveoli. Okay, you decreased it because the nitrous oxide went rapidly into the blood, and now you get a tremendous increase in number of percentage of the isoflurane. That will help push the medication in more rapidly. That's called the second gas effect. So it's beneficial to use nitrous oxide when you're doing an induction on a person. It gets you a much more rapid onset of effect if you do that. Okay? Now, the second gas effect will apply to any agent that's insoluble like this. And when you're talking about the newer gases, which we'll talk about sometime next week, which is xenon, it also has a second gas effect. Okay, so you can actually use some of these agents to have second gas effects as well. The second gas effect, if you look at this example, let's take you got two examples. You got one, we're using nitrous oxide at 70%. You can see that the person gets up there pretty quick with 70%, versus 10%. It takes them a little longer to equilibrate. But if you use halothane and add to it, it significantly adds concentration. If you're using 70% nitrous oxide, and the second gas effect will give you the concentration in the bloodstream will be much higher for the halothane when you add the nitrous oxide because of the second gas effect. So it makes the induction occur much more quickly when you're adding nitrous oxide to halothane. This is again another picture. This is the same example for desferrine. If you use desferrine with nitrous oxide, you can see how fast the onset is versus if you use desferrine with just 5% nitrous oxide, it takes a lot longer for the medication to kick in. So if you really want to make a person get the anesthetic on board much more rapidly, it's smart to use nitrous oxide, which is one of the benefits of it. Okay? People have this kind of clinical distaste for nitrous oxide, which I'm not really understanding, because if you look at the science behind it, it doesn't really make sense. What they've literally fed into is what the pharmaceutical companies have told them, that nitrous oxide is bad. And the reason they're being told that is because they want to sell more volatile anesthetic. Okay? If you give nitrous oxide, what happens to the actual MAC of desferrine? It decreases, so you use less of the agent. So it makes sense to, if you're the pharmaceutical company and you want to sell double your agent, tell people that nitrous oxide is bad. Okay, so you need to look at the literature a little more carefully, and especially now you get to look about who's actually writing the papers. Because there's so much bias, it's actually pretty disgusting to watch. Okay, people have just sold their souls almost. So just use nitrous oxide when it's appropriate. Nitrous oxide is not always appropriate, but it's appropriate when you need it. Okay, and induction is a clear example where it can really help you make a difference. The other thing that's important about using nitrous oxide in comparison to pure volatile anesthetic, which I'll show you what's called the ceiling effect, is that nitrous oxide is supportive of ventilation. And the more supportive of ventilation, the more rapid the induction takes place. So nitrous oxide is a double benefit. Okay? Versus if you use straight volatile anesthetic, I'll show you a picture of it, it slows down your induction very badly because every time you increase the concentration of volatile anesthetic, you suppress the brain center to breathe. So it slows your induction. So rate of rise of the alveolar concentration resides on minute ventilation, and that's the next concept. So the faster your minute ventilation, the more rapid your alveolar uptake takes place. So if somebody is able to maintain their minute ventilation better, you get a much more rapid uptake. Okay? And the other part is also important, is functional residual capacity. And functional residual capacity can be a very significant limiting factor. Now let's look at the downsides. Let's say you see what's the downside of increasing alveolar ventilation. Okay, so if I mechanically ventilate you and increase your alveolar ventilation, there is downsides. Everything in medicine has got its upsides and downsides. Part of what you need to learn in pharmacology is that you have to understand all the benefits of a drug and all the downsides of the drug. Not listen to what people are telling you and they say, oh, this is the best drug ever. You know, my answer to that is, if it was the best drug ever, then why doesn't everybody use it? And the answer, they usually look at you and they walk away. Because they're giving you a biased opinion. Okay, every drug has its benefit. Every drug has its disadvantage. It's applying it to the situation you're in that you need to learn. What I try to teach you is, I try to teach you the toolbox method, where you have 20 tools by the time you're finished. If you want to limit your life to being everything a hammer, hey, go ahead. Everything will look like a nail to you. Okay? But then when you run into a screw, you're going to get screwed. Okay? So try to be careful. Okay? As for your rapid decrease in CO2, that's one thing that happens when you start hyperventilating somebody or increase the ventilation. You can get cerebral vasoconstriction, which actually decreases the distribution of blood to the brain, so that can slow down your emergence. You can get peripheral vasodilation, which of course will cause your blood pressure to drop. You can also, when you start doing this, is you increase the mean airway pressure, which then limits your preload return to your heart, which leads to a decrease in cardiac output, which then decreases your distribution. The rapid rate of rise of agent may actually lead to overdosage, which could be an issue. And overall, your effect is a drop in blood pressure, okay, which is what the book says. But I wanted to sort of piece it together for you to show you that the reason that's happening is because you're actually mechanically ventilating that individual too aggressively. So be careful of doing that. Now, when you look at the alveolar ventilation to your FRC ratio, okay, and what they're showing you here is that in children, when you put them to sleep, they go to sleep really fast, okay? And the answer is why, okay? Because it's a simple equation of the greater the alveolar ventilation to overall FRC, the more rapid the onset of uptake, okay? So people that have high minute ventilations in comparison to their FRC will tend to go to sleep much more rapidly. And that's a perfect example of a neonate. A neonate is breathing 35 breaths per minute, usually. Okay? So he has a high minute ventilation. Okay? And his FRC is not real high, so when you look at the ratio, he's got a 5-to-1 ratio compared to an adult. So he's going to go to sleep really fast when you give him an inhalational anesthetic. Okay? So they have a very rapid uptake. On the other hand, adults have a minute ventilation to FRC ratio of only 1.5 to 1. So they're still a little bit greater than FRC, but it's limited. Okay, so adults tend to go to sleep much slower with inhalational induction. The older the adult is, the number goes more to 1.5 to 1. If you're getting a kid like that's 12, 13 years old, can you still do inhalational induction? Absolutely. These are maybe around 2 to 1. Okay, but as you become more of an adult, are you still able to put somebody to sleep with inhalational induction? It's absolutely. I do this all the time to teach it to students because students say, I can't put somebody that's an adult to sleep. Well, that's not true. Okay, and a clear example is, say, somebody who's got a poor IV access, who is NPL, but nobody can get an IV. Well, perfect case of doing inhalational induction. You start on 50% nitrous, let that person breathe that for a while. They don't get any reaction to nitrous because nitrous is non-pungent. You'll watch them breathe. Okay, down to 50%, they'll get lateral nystagmus, they'll get whacked out. You tell them to look, and they're sort of drifting all over the place. That means they're already gone. Their memory is not going to be existent. And then you crank up the SIVO up slowly, and then you see the person just go off to sleep. And it's a beautiful method. As soon as the SIVO gets into your bloodstream, what does it do? It's a peripheral vasodilator. And what do we need to get an IV? Peripheral vasodilation. So then the arm veins get huge. And even my friendly intern could get one IV in that person across the way. So peripheral veins have actually become really easy to put in when you just put the person to sleep. Okay. Now, what about spontaneous versus mechanical ventilation? This is where I have an issue. And this is where if you ever look at Eager's lecture, Eager is a great guy, but one of the things that he's been telling people not to use nitrous oxide, but when you look at his videos and you look at it carefully, you'll see that he's using nitrous oxide, especially for induction. So I don't know. I have my biases too, I guess, but You know, when you're using something and you're not telling people why you're doing it, this is the reason why. If you're giving a straight volatile anesthetic, it's a respiratory depressant, okay? And it really limits the amount of uptake and spontaneous ventilation. So let's look at this graph. This is somebody who's spontaneously breathing, which is what you're doing on inhalational induction. And what they did was they increased the MAC value of the volatile anesthetic. In this case, they're using mostly sevoflurane. And you can see what happens to sevoflurane when you increase it to 4%. What happens to their FA-FI curve? It actually slows down dramatically. And you wouldn't think that, right? Because, geez, you know, I have a higher concentration, it should get there. Didn't you just show me that, Dr. Nolan, with nitrous oxide? And the answer is yes, with nitrous oxide, but nitrous oxide is supportive of oxygenation and ventilation. Not supportive of oxygenation, but supportive of ventilation. Okay? So, but the volatile anesthetics don't do that. The volatile anesthetics all depress respiration. So as a consequence, even if you're increasing the concentration, unless you take over for that individual, they're going to be stuck there. So that's one thing we teach you as well. Once a person starts breathing and they start getting, their minute ventilation begins to fall, we tell you take over, help. Okay? And when you bag in the system, you're going to get in that concentration to where you want it so that person goes to sleep. Otherwise, you get stuck there, and now you can stay in phase 2, and then you're in trouble. Okay? That's what you want to get out of. That's how desflurane can get you really into trouble on induction. Desflurane is so insoluble that if it gets stuck at a certain level and you can't get them, and it's such a respiratory depressant, that you can't get them through it, if you can't get them breathing and they go into bronchospasm on you, you're really in a bad spot. You can't get out of it. And I put one of the few kids to sleep when we were told that desflurane was safe to put to sleep with kids. The kids turned blue, all of them. It was scary. After the 4th kid, we called up and said, you know, we're having real problems here. After the first 2 kids, we called them up that day. And we're having big problems with this, okay? We're seeing kids turning blue on us. And they said, oh, well, you're doing it all wrong. So they actually sent the guys over, which is one of them was eager. He came over and looked at us and said, you guys are doing it all wrong. I said, okay, well, I'll sit back and watch the expert do it. Well, the expert turned the kid blue too next, okay? When you have the expert doing the turning blue, it's not the expert, it's not me, it's the daggone agent, okay? So because of that, I wasn't really a fan for desflurane for a long time, okay? So in certain agents, they're very limited in their insolubility, and they suppress the respiratory drive so much that you can't get the concentration to go up. Versus, if you take the same situation, now you mechanically ventilate them, now it follows the same curve as the nitrous concentration curves. Okay? So the reason the difference is one supports ventilation and the other one doesn't. And this is another clear example to show you that nitrous is actually very supportive of ventilation. Okay? Solubility is denoted by the partition coefficient. That's the next concept. You have blood gas partition coefficient. The partition coefficients can reflect the capacity of each phase to accept anesthetic. If I have a blood gas partition coefficient of 2 to 1, then you have a blood gas value of 2. This means that when the calibration is established, you have 1 part of gas in the alveoli and 2 parts of gas in the blood. This gas is actually very soluble then. Versus if you have a gas that has a blood gas partition coefficient of 0.5, that means that you have establishment of 2 parts of gas in the alveoli for every 1 part in the blood, and this reaction is actually very insoluble. Okay? Usually the number that we look at is for solubility. If we give you a number of 1 or less than a number 1, that's an insoluble agent. Anything that's between 1 and above to, let's say, 2 or 3, that's considered an intermediately soluble agent. And if you're above 3, then you have a very soluble agent. That would be like ether and chloroform. Okay? Solubility is ultimately dependent on particle velocity. Okay? So temperature is going to be a factor. And if you increase temperature velocity, then you actually increase the solubility. So the gas is able to penetrate through the membranes more rapidly. Now, comparative-wise, you need to understand and memorize some of these numbers. I don't expect you to memorize everything, but I do expect you to memorize the blood gas partition coefficients of the agents that we use, okay, which is isoflurane, sevoflurane, nitrous, and desflurane. Those are the ones I expect you to know by heart. You have to know the blood gas partition coefficient of the isoflurane is 1.46. Sevo is 0.69. Nitrous oxide is 0.46. And the least soluble agent that we use is desflurane, which is 0.43. Okay? So these are, what I've done for you is I've broken down into the soluble to intermediately soluble to the low solubility agents. The agents where they cut it off is around 2 to make it the more soluble, which is fine. Some books will do it that way. The intermediate soluble agents are the ones between 1 and 2, which is isoflurane, enflurane, and halothane. The other thing that's important in looking at these numbers is the oil-gas to partition coefficient. The oil-gas to partition coefficient can be correlated to the potency or the MAC value of the agent. Okay? The lower the oil-gas partition coefficient, the less potent the medication is, and it takes you more of that medication to be equal to 1 MAC. Okay? So an agent like isoflurane is actually going to be much stronger, much more potent than both sevoflurane or desflurane because of the oil-gas partition coefficients are different. The other thing that I want you to also look at is the muscle-to-blood partition coefficient. The higher the muscle-to-blood partition coefficient, the more penetration of the anesthetic into the muscle group, and as a consequence, it causes more muscle relaxation. Doesn't mean it doesn't cause any muscle relaxation, but it does effectively get into the muscle and cause the muscle to lose its function. Okay? You can see desflurane still has pretty good muscle activity. It's 2. It means 2 parts for every part that's in the blood is actually getting into the muscle. So desflurane actually is actually an okay muscle relaxant. But the one that's actually much stronger is actually isoflurane or sevoflurane. Sevoflurane, when you look at the blood, the muscle blood partition coefficient, would indicate to you that it would be the strongest. Which it is if you look at the number only, but when you look at potency, which is MAC value, fluorine is actually much more potent. So even though those numbers are pretty close together, that usually that isoflurane, if you want somebody to be intensively muscle relaxed, isoflurane is a very, very good agent. Okay? You can see halothane is actually the most. And in the old days, we used to use halothane to invert uteruses. So when the uterus would actually get flipped on us when they're doing a C-section, we'd actually crank up the halothane, and that uterus would get completely soft, and they'd be able to flip the uterus back into its normal position. So Sevo is a great agent for that muscle relaxation properties. Halothane, sorry. Okay, the impact of solubility, the less soluble the agent is, the more rapid the rise on your FA to FI curve. You can see your nitrous oxide is rapidly rising. The reason nitrous oxide exceeds desflurane is why? That's right. Because the maximum that you give in sevoflurane is around 7 to 8%, versus nitrous oxide you're delivering anywhere between 70, and then this example they put it at 80%, I think. So you can see the vast differences just because you get more particles. If you were to put it at 6% nitrous, it would never get very high like that. Okay? But desflurane would be at its maximum point. It's still more rapid than all the other agents because it's so insoluble. Okay? Sevoflurane has a pretty good curve too. That's very reliable and it has pretty rapid onset. I put somebody to sleep with isoflurane, volatile-wise. You can be done. It's not fun because it takes a lot longer, but it can be done. But the more soluble the agent, the more the alveolar ventilation will have impact on uptake, and the better off mechanically ventilating you are by using the more soluble agents. So desflurane, you really need to take over very quickly if you're doing an induction on an adult. I've done it. It's not something I like too much because they start getting bronchospasm, and they have so much respiratory depression with desflurane that I'm not a real fan of doing an inhalational induction with it. I'd rather use Sevo. So Sevo is a great drug. Now, soluble agents have decreased uptake. They can be overcome by increasing minute ventilation and overpressurization. And by overpressurization, we mean by turning the dial up to above MAC value than you expect. What are the effects of blood gas partition for solubilities? If you increase the solubility, it slows down your induction speed. So if somebody's eating a lot of fatty meals, you can actually decrease the solubility. Sorry, you decrease the actual uptake. You can increase the uptake, and because of that, the alveolar concentration falls more so, and actually will then slow down your induction. Okay, your intermediately soluble agents can also be seen to be affected by age. As you can see here, this is the age in years. Okay, if you have somebody that's in the age group around 30 to 35, That's where you're going to get the least amount of blood gas partition to be effect. Okay, so kids are much more sensitive to these medications, and as you can see, also elderly adults are also beginning to show more impact. Okay. Well, the other where you see decreased solubility increases induction speed or things like anemia. If you have a 21% hematocrit, has 20% less solubility than a patient with hematocrit of 43. So that means when you give these agents to these people, you'll see that they'll get a much more rapid onset. It's only in the intermediately soluble agents as neonatal blood is less soluble than a young adult that it really matters. And only in intermediately soluble agents as elderly blood is less soluble than in young adults as well does it matter. So we're looking at isoflurane and halothane and enflurane. We're not talking usually about desflurane and sevoflurane as being, and nitrous oxide being affected by this at all. So you have to take that, these are low solubility agents, so those are not impacted by those kind of effects. If you look at your tissue partition, blood partition coefficients, it'll tell you how long it takes for equilibration to take place. Time constants can actually be determined at the time to reach equilibration. It takes 3 time constants to basically reach 95% equilibration. And the equilibration for the arterial to the brain depends on solubility and usually can take as much as 5 to 15 minutes. And that's important for you to know. If I change the dial, I shouldn't expect the medication to have its peak effect right away. It's going to take 5 to 15 minutes. So if you're a person that likes to play with the dial all the time and doing this every 30 seconds, you're doing nothing. You're just wasting your time. Okay? Turn the dial, give it a second to see what happens. In other words, give it 5 to 10 minutes. By the time next cycle blood pressure, the next cycle blood pressure is falling, then cut back. That means you gave too much. If you see no effect, still wait. Give it another 10 minutes. You're still peaking. If at 10 minutes you see that the pressure begins to fall, then cut back. Look at your exhaled concentration and then cut back to usually about 10% above that. And that usually will give you a nice equilibration so you're not playing yo-yo effect. A yo-yo effect is when you're overdosing, underdosing, overdosing, underdosing, but you turn the dial too many times. You're going in between the cycles and not catching it in the right position. The 3 tissue blood partition coefficients that you really need to pay attention to is the brain to blood, the muscle blood, and the fat to blood. Because that will tell you 2 things. This will tell you how fast an onset it's going to have on the brain. This will tell you how much muscle action you're going to have. And this was going to tell you duration of action, okay, or long-term duration of action. If you have a high fat to blood component, that means that person who is going to be more morbidly obese is going to absorb a greater amount of that medication, and the more problems I'm going to have in trying to merge that individual. And that's what these values are for, to look at. So sort of review them and sort of have an idea. And these are the kind of things that will make you determine which agent should be used for what patient. Okay? So we'll stop there. We'll start on let's see where we're at right now. Tissue. Yeah, we'll start on tissue blood partition coefficients, number 26 next week. Okay?